honored speakers, Dr. Franklin Ehis Bremen, consultant orthodontist, and National Secretary General, Nigerian Dental Association. Dr. Franklin Bremen is a distinguished leader in African dentistry, currently serving as the National Secretary General of the Nigerian Dental Association, a consultant orthodontist and head of the Department of Dentistry at the Ilua Specialist Teaching Hospital. Dr. Abrimen combines high-level clinical expertise with significant health management experience. He holds a fellowship in orthodontics from the West Africa College of Surgeons and a master's in health planning and management. Throughout his career, he has held pivotal leadership roles, including National Assistant Secretary General and National Welfare Chairman of the NDA, where he has been a vocal advocate for professional welfare and system healthcare reform. His unique blend of clinical mastery and administrative leadership makes him a primary voice in shaping dental policy and specialty practice in Nigeria. You're welcome, Dr. Ablime. We are with Dr.
Thank you very much.
Yeah, thank you. We are with Dr. Wenje Robert, who is dental surgeon and director of In-Depth Community Dentistry Africa Limited. Dr. Wenje Robert is a results-oriented dental surgeon with over a decade of experience spanning clinical excellence and community-driven initiatives. Educated at Makerere University Dental School, Dr. Bwenje has cultivated a diverse clinical portfolio that includes orthodontics, oral and maxillofacial surgery, and pediatric dental care. Beyond the clinic, he is a dedicated advocate for oral systemic health, serving as the director of In-Depth Community Dentistry Africa Limited. His leadership history is rooted in organized dentistry, having served as a country representative for both the International Association of Dental Students (IADS) and the African Dental Students Association (AFRO-DSA). Dr. Bwenj is widely recognized for his patient-centered approach and his commitment to using Ubuntu to bridge the gap between professional dental care and community accessibility. Most welcome, Dr. Bwenj Robert. We are with David Odoi Watanda, who is a Public Health Dental Officer and Executive Director of Dental Health Uganda. David Odoi Watanda is a dynamic public health professional dedicated to expanding oral healthcare access through grassroots advocacy and education. As a public health dental officer, he serves across multiple prestigious institutions, including St. Francis Hospital, Nyenga, Specialist Doctors International Hospital, and Doctors Clinic, Jinja. A passionate educator and leader, David serves as a part-time tutor at the Tororo Institute of Health Sciences and is the executive director of Dental Health Uganda, a prominent charity organization based in Tororo. His work focuses on the front lines of dentistry, conducting dental camps, providing essential oral health education, and implementing the basic package of oral care in underserved districts. David's career is a testament to the power of community-based interventions in transforming national oral health outcomes. You are most welcome, uh, David. We are also with Dr. Ridit Zelihun Abebe, President, African Dental Students Association, AFRO-DSA, and Doctor of Dental Medicine. Dr. Ridit Zelihun Abebe is a dynamic leader and a rising force in African dentistry, currently serving as the president of the African Dental Students Association, AfroDSA, a graduate and Addis Ababa University's College of Health Sciences. Ligit has distinguished herself as a passionate advocate for the next generation of the oral health professionals across the continent. An extensive background in student governance and international liaison complements her clinical expertise as a doctor of dental medicine (DMD). During her tenure as a student leader, she served as a crucial bridge between the student body and faculty management association budgets, coordinating large-scale events and fostering a culture of mentorship. Now reading Aphrodite, Dr. Edith is dedicated to aligning dental education with the practical healthcare needs of Africa. She is a vocal proponent of universal health coverage and is committed to integrating youth perspectives into national health policies. Her work focuses on empowering dental students and early career professionals through capacity building, ensuring they are equipped to drive innovation and equity in oral healthcare delivery across Africa. You are much welcome, Dr. Edith Abebe, and welcome, Dr. Bwenje Robert. Uh, the topic we are going to be talking about, we are going to discuss oral health in national health policy as of the Dental-Medicine Chronicles of today. I apologize for this host. She was not able to be certain at the point. I'm Jimmy Confiance Gisubizo, the president of Dento-Medical Society, Rwanda. We are going to be together in this session. As a start, I would like to call upon Dr. Franklin A. Abrime, the the president, the secretary of Nigerian Dental Association, to discuss with the point saying what is the policy in entry points we can use to ensure oral health is funded alongside other non-communicable diseases. You're welcome, Doctor.
Yes, thank you very much for having me on this call. I bring you greetings from the Nigerian Dental Association. It's good that we are discussing a topic as apt as this, and keep thinking of how would oral health keep being recognized as a non-communicable disease. And we know that when we get it as a non-communicable disease, recognized fully as a non-communicable disease, then there will be a lot of concerns, and there will be a lot of funding, and there will be a lot of support to the actualization of quality oral health. As we all know, in 2021, the World Health Assembly included oral health into classified it as a non-communicable disease based on the fact that we know that alcohol consumption, tobacco consumption, use of sugar and other things can actually cause oral health diseases. And we know that with the idea of having universal health coverage, we want to make sure we can have access. In fact, we don't want more of curative. Before now, everything we talk about is curative in dentistry because everyone waits for the time when they can. It's gotten so bad and they need to measure the pain versus the finances they will need to let go of before they can seek oral health care. But like we know, not until we get funding for oral health care, we really cannot actually practice oral health. You can't. The population will not be able to get quality oral health care easily. And when we're talking about integration of oral health into the non-communicable, it has already been classified at the World Health Assembly. However, we need to localize them in our various population. As an association, the Nigerian Dental Association, we have been able to set up a panel, a group of dentists and dental allied workers, and we have been able to get up a strategic plan which is spanning from 2026 to 2030. And the idea is we have written out a very wide policy that will talk about how we can integrate oral health care. And we are making them see it as a non communicable disease. And there are several ways we can actually make this happen. So, definitely, like I rightly said, we can integrate it. We need to do it locally in our various locations. It has been stated at the World Health Assembly. Now we need to go and make it happen in our own various locations. And how do we do it? We need to get legislative support. We need to have a policy document of our own locality, and we need to find a way to get legislative backing, and from there you can actually get funding when you get a line of budget, when your oral health can fall into a line of budget. Like in Nigeria, our parents do not have a line of budget for oral health. It is incorporated in several other things that you need to sneak into to be able to get oral health funded. So it's a little challenge we get to do. But what other ways can we do? Why don't we incorporate oral health into primary health care? In Nigeria, as a case study, oral health has been incorporated into primary health care. However, it has not been implemented. So, what are we doing? Not until oral health is fully implemented into primary health care, we cannot have a very viable oral health for the population. So there are several things we need to do. We need to push our policies. We need to make sure that we are getting legislative backing. We need to make sure that we are having a source of funding, and we are having our line of budgets. And I believe that if we keep pushing it under the non-communicable disease pattern, I'm sure we'll be able to do well. Like the sweet sugar taxes that we are pushing for. In Nigeria, we have a committee, and the Nigerian Dental Association was incorporated into this committee. So if we can keep going through there, we can get funding for preventive oral health care, then that can actually tell us that we'll be able to get good oral health for the population. And also investing in our NHA. If we can get our NHIAs, our insurance schemes, to be able to treat oral care as primary care, so that we can get scaling and polishing, basic fillings, basic oral health packages, and preventive ones. Scaling and polishing, fluoride application, fissure sealings. If you can get them into the primary healthcare space, then we'll have a lot of prevention of oral diseases, and definitely the oral health of the population will be better. Thank you so much. I think I won't want to boss with so much talk, but if there are other things you need me to say, I'll be here to talk. Thank you.
All right, thank you, Dr. Franklin. We appreciate the greetings from Nigerian Dental Association, and it's a pleasure with us to be with you. We appreciate what you shared with us. Really interesting, and I would like to ask you. You say to get the support or to get the oral health pushed in the national health policy, there we need a registrative support, like as a dental practitioner or as a dental reader as well. How do we expect, or how can we make this? How can we get it, or how do we expect that the countries should be contributing to oral health to get that support, and which might increase the availability of dentists and they get recognized in the national health policy?
Yes, like I rightly said, um, we need to be political. We as dentists, we are very close to our clinics. We spend time in our clinics. We do not advocate that much as we should be doing. I think we can do more, even though we're trying our best, but I think we can do more. And I even feel at the level of training us, even in the school, we should be open to political experiences. We should be open to even becoming legislators ourselves. Because definitely, I know that if we have one legislator in our various countries as a member, as a legislator, we can actually push it through those legislators. They'll be able to sponsor your bill. And before you know, you can have it on the floor of the house. And before you know, if it's well presented, it can be approved. But unfortunately, a lot of us are busy in our clinics. We are busy, trying to do as much as we can, which is not bad. But I think we should also encourage ourselves to do this. And if you don't even have dentists in the houses, in the various House of Representatives and assembly, we should also follow and do advocacy. There's room for advocacy. The person doesn't necessarily have to be a dentist, but you can find interrelationships from where you have prepare the documents for them, explain the documents to them, and definitely you can get people that are interested. Like our own strategic planning we are having right now, we are pushing it to see the minister. We have plans to see the Minister of Health and Social Welfare in our country. Presently, the president is in Abuja he was there yesterday trying to see how we can get it to the hands of the Minister of Health and Social Welfare, where that can actually, from there, when we have a document that is approved, we can now take it to our a legislator or some take to the can take it to the health committee in the house, and from there they can assign you to a legislator who would now push up the bill. We can now create them into bills. Now we have a big document. We now divide them into several bills because we have bills. We have segments that talk about the academic part, the need for training more manpower, the need for integrating into primary health care, the need for, several segments. So we're going to bring them out individually, and we'll now sponsor it as a bill. It's a tedious task, but I feel it is doable. And not until we incorporate it into a line of budget, because the point we are going with is this is a non-communicable disease. We need to prevent oral diseases. Oral diseases can be prevented, and not until not until we don't stop talking about it that way, we won't get the attention we desire. So yes, we need to lobby our advocate a lot with our legislators in our various countries, and we need to do the work. Thank you very much.
Uh, all right, thank you, Doctor. That's a very good insight, and we appreciate. And we as dentists, we have to push this to the implementation of the national health policy that we are discussing. And by that, I would like to ask you another question. You've said that Nigeria, you've successfully integrated oral health into the primary healthcare. And I would like to ask you, why do you believe oral health should be considered as the primary healthcare in the national health systems? Thank you.
Yes, in our country, we have been able to officially, on paper, integrate oral health into primary health care. So they added it some few years ago, and they added it along with mental health. Unfortunately, up until now, we have not had any good integration. So we do not have the dental presence in our various primary healthcare centers in the country yet. And this is over 7 years of this discussion, and we have still not gotten that result. It's a difficult thing to, it's one thing to state it in the paper, it's another thing for implementation, because that will require funding, that will require training of manpower, that will require posting manpower to the various primary healthcare centers and all that. I believe that integration of oral health into primary healthcare, number one, would bring oral health closer to the people. So everybody can go to the primary healthcare center near them and have someone to do preventive cares for them. We'll be able to do basic oral health care services for them. And the ones that can't be done at the primary level will be referred for secondary care. And also that will also help us with manpower. So A lot of our dental surgery assistants, our dental hygienists, dental therapists, and even dentists can also have a position in the primary healthcare system, whereby they can also provide healthcare, to the people, to the population, the grassroots. Those are the people that actually need this oral healthcare, So we can actually get to the underserved down in the villages, because dental practices are not usually in the rural areas where we have the highest population of individuals. Rather, we are all in the urban areas because of the number. Presently in Nigeria, we still have less than 4,000 dentists, in the country right now, of which we still have about, maybe a lot of them have migrated. We barely have 3,000 in Nigeria to take care of our over 250 million population. So that tells you that we have passed, our limits are small, so we really cannot even think of rural areas, and even most of us are enclosed in the urban area. So the rural areas are still suffering. The rural areas need help. We need to take primary health care. Then, if there are good packages for the dentists, the dental hygienists, the dental therapists, the dental nurses, the dental surgery assistants, then they are going to be encouraged to go towards those areas and also serve the population. So for us, I personally, I believe that integration of oral healthcare into primary healthcare is a win-win for us. It's a win-win for the population. It's a win-win for the country, and it's a win-win for we, the oral healthcare providers. Thank you.
All right, thank you, Professor Dr. Franklin. And in the chat box, we are having a question from Dr. Nilanjan saying, how do you decide the balance between auxiliary workforce and the clinical workforce determination? He said he meant producing dental therapists for the country rather than dentists or specialists. Dr. Franklin? Hello?
Yes, we can't underemphasize the use of dental therapists, dental auxiliaries, and other healthcare professionals. We know what it takes to train one dentist. It's not a very cheap training for a country, especially a country like ours, where they train us for free. We probably barely pay tuition. We get support from the government to be able to study dentistry. If the government is not supporting in the government schools, public government schools, definitely we probably will not have dentists in the country, because to really train someone in dentistry is very, very expensive. If you look at the cost it costs to train a dentist in America and UK and other countries, you will know that yes, we are not paying anything to get it. We are getting it practically for free. That as is may, we also know that dentists will really not want to go to rural areas as much. Presently, I practice in a rural area, a semi-urban area, which is actually Irua, not the main town of Edo State. I practice outside there, and I see that as I'm speaking to you, I'm the only orthodontist in the whole of that region. And how many of those are dentists? There are barely 10 dentists in the whole of that region that has a high population of patients and individuals that require oral health. We must balance it. Like I can rightly say, in the various primary healthcare centers, in various wards and communities, we might not have a dentist in there. So we could have our dental hygienist that can actually see cases and say, oh, this one requires a more professional work. Some might just see preventive cases. They can do mobile extraction of mobile teeth. They might be able to do some basic fillings. But when it comes to things that are more delicate, we can have at least in one local government area, have one dentist, and those ones can be referred. The patients can be referred from the community, these various communities, the various PACs, to one central PAC where we can get a dentist to see them. And that will not take them a long journey because it's still within the local government area where they reside. And so we need to balance it. Yes, I know that we don't want to allow, don't want to say we might have quackery and all that. No, but definitely we can't have dentists in every primary healthcare centers. That means that will not, in Nigeria we have about we have how many local we have several local governments in Nigeria. The number of local governments alone will be able to eat up, a huge sum of dentists we have. So we need auxiliaries. We need trained auxiliaries, trained dental therapists that will be able to do these kind of jobs that we're talking about in terms of emergency, in terms of preventive care, and knows when to refer. So they need to be trained for this purpose. It's not someone that will just graduate from the school and we send them. No, we'll train you for this purpose. So I think we can balance it that way.
All right, Dr. Franklin, we appreciate the content that you shared and the insights. Is really interactive session, and please allow me to go forward to the next speaker, Dr. Edith Z. Abebe, and I will be back on to Dr. Franklin at the probably at the end of the session and with the questions got from uh, the audience. Uh, Hello, Dr. Edith.
So thank you. Uh, well, I will say my points on how
Dr.
can
Edith,
national.
hope you're doing well.
Yes, yes, yes. Can
Uh,
you hear
uh,
me? Am I audible?
Yeah, sure. I would like to ask you a question. How can national policy incentivize students and early career professionals to serve in high need and underserved areas?
So, from the African Dental Student Association point of view, and as a person who has worked on different national organizations, student organizations, so I would like to suggest that national policies can play a role in a transformative role, like in directing students, early career dental professionals toward the underserved areas. So, in order to do this, it must go beyond obligation and it must create very meaningful incentives, which is relevant to trainings and dignified career pathways. So, the first thing that should be done is financial and career incentives are essential. So, um, we suggest that the government should implement scholarships, tuition waivers, student loan, so that um, these programs are tied to service and high need areas. So this must be complemented by competitive salaries, rural hardship allowance, and house support and clear pathways for career advancement. So serving underserved areas or communities should not feel like a sacrifice. It should feel like a respected and rewarding professional choice. And second thing I suggest is that I must embed community-based training into dental education. So, embedding this community-based trainings into the dental education system, it will allow students to be trained, not to be trained. Students should not be trained only in the urban areas. So, all or in the well-equipped institutions. So students should be able to be trained also in the rural and peri-urban settings where the majority of our Africans live. So it will help us to have an early exposure through rotations, either internships and outreach programs. So it's going to help students to build familiarity and confidence and a sense of responsibility towards the community. So training must reflect the we highly suggest that trainings should be able to reflect the epidemiological realities in our continent or in specific African regions. So, high burden of preventable oral disease, limited resource, and links between the oral health and overall public health should be linked together. The other thing, this policy should be able to invest in infrastructures and working conditions. So incentives, no incentives will be sustainable if young professionals are deployed into environments where they cannot practice effectively. So clinic must be equipped and supply chains must function and be supported, and supervision must also be available. So technologies like teledentistry can reduce this professional isolation and improve service delivery. And integrating public health and advocacy into the dental curriculum will help. We believe that. So the next generation of the African dental professionals, they must be more than a clinician. So they must be advocates, educators, and policy contributors. So by equipping these dental students with skills in prevention and health promotion, leadership, and policy engagement, we can ensure that they can actively shape and implement national health priorities. So, I finally suggest that recognition and professional dignity matter. So, national award and career fast tracking and leadership opportunities for those serving and underserved areas should be, they send a powerful message that this work is a valued, visible, and also very impactful. So the solution lies in aligning incentives, education, infrastructures, and professional identity with the goal of equitable access. So if we train students for the real Africa, support them in serving it and recognizing their contribution, I think we'll be able to build a workforce that not only fills gaps but transforms community. So that's what we believe. Thank you.
Thank you very much, Dr. Adit. You have shared uh, a very interesting session and really understandable. In the basically in the concern of the student and integrating the student or learners of dentistry into the professionalism and also uh, enhancing them for the profession. Having a question saying, how do you believe? You said it's I believe it's better that the students should be involved in the committees like NDAs or National Dental Associations and other superior committees that they get trained to that and they get exposed uh, to that with that exposure they get that exposure and they get that experience and how do you believe or how do you see this should be done and what is it going to improve as per curriculum? Thank you.
Early exposing the students is going to allow them to see their community. So we believe that funding and incentives will help this students to be more closer to their community. So the way to bring the students closer to their community is funding, and as I've said, probably loan forgiveness and scholarships and tuition fee waivers. It's going to help students to be closer to their communities, and rather than feeling like it's a burden to serve this underserved community, it should feel like a reward. So the government or national policymaker should take this into consideration, and they should be able to fund this. And the other thing is, um, sorry, what was the other question?
The other question says, how is this going to integrating the students in the committees of these specialties in dentistry, or those who are the seniors of dentistry? How is this going to boost the students as per curriculum?
So integrating it into the dental curriculum will help them to advocate So they're going to know more about the epidemiological status, and it's going to even minimize the gap between the seniors and the juniors too. So if this is integrated into the curriculum, then there will be equity and distributions. So it's going to help them to they're going to have a data provided and population ratio, so it's going to help them advocate, and it's being part of the dental curriculum will make them closer more to the community, because they're going to see it, advocate while learning. So it's going to be part of the dental curriculum, and they're going to work on their daily dental school life. So the more they work on it, the more they know their communities, and the more they're closer to the underserved community.
You're right, Dr. Dit. The more they get exposed, the more they get more knowledge. And I would like to ask you the question. You say that we need to integrate or to put the students in rural and urban settings. Uh, how are we going to make it? How do you suggest that it should be implemented or suggested to be done? That we get the students really aware of the community or the reality of the art or the public that they are serving.
So the first thing that should be done is training should not be only available in the urban or well-equipped institutions. So the rural and peri-urban settings, as the where of the majority Africans live. So this community-based training should be available in this rural and peri-urban settings in Africa. So a really low early exposure through rotations. Either it could be internships or community outreach programs, or any attachments that could be available to build the students' familiarity with their community. So it's going to either ways build their confidence, and it's going also to give them a sense of responsibility. The other way to bring this is it's not possible to send the students to this underserved community without any financial aid or any financial support, because we suggest that the government should implement, and other professional associations should also take in charge with this, and advocate with the students, and whoever is in charge with this should advocate at a governmental level, because as I have been trying to mention this previously, financial and career incentives are very essential. So either any scholarship, tuition waiver, even a student loan forgiveness program could be tied to services in high need areas, so that be complemented by competitive salaries or rural hardship allowance or housing support and clear pathways for career advancement. So this way, it could be easy to serve the underserved community. It's going to it should feel like rewarding, and it should be done with respect, not with a burden. So financial support and is very essential to do this. Uh, that's what I would like to suggest.
All right, Dr. Dit. As the AfroDSA president, you've been exposed to this environment of students many times with different dental student associations. As AfroDSA, how do you manage, or how do you come up with the solutions for the financial and incentives issues by students' initiatives? Uh, how do you come up with this, or how is it?
So, as a 40 president, yes, I've come across with different students, and yes, with the financial issue with a serious problem. But um, as a 40 I would still suggest that it's not African Dental Student Association should advocate for this integrating this students into the underserved community. So the government should take part in financial aiding to students. So yes, this is not something that African Dental Student Association can can only tackle or can only focus on, but African Dental Student Association should advocate for this so it can bring the underserved community and closer to the students and even other senior community. That's why I believe advocacy is a very crucial. So we need to advocate.
All right, thank you, Dr. Edith. In the chat box, there is a question raised by Dr. Niranjan saying he was asking about, can we have uniform curriculum across African continent? This question will be answered by you, Dr. Edith, and in the later time, I will address it to Bwenje once I give him a floor. Uh, how do you feel this, Dr. Edith?
Pardon, please.
The question says, can we have uniform curriculum across African continent?
Um, I mean, it's possible, but not really something that is going to happen within 6 months or a year. But yes, it's possible because, as you have seen, other continents have a uniform curriculum. It's either the Bachelor of Dental Science or Doctor of Dental Medicine or the Dental Assistant course. But in Africa, we have different curriculum. But if we take it seriously and we need what's missing in the African continent is we don't have a professional association, which we are actually lacking that, and we only have the Dental Student Association. But I can see that this African Dental Congress is working towards that to bridge the gap between the students and the professionals. So if this gap is, if we can bridge this gap and work on this, yes, the Dental Student Association can work with the professional associations, and then we can have a uniform curriculum. But in order to do this, it's something that should be done together with the professional association and the dental student association, where we come together, work on it, and present our concern to the governments of the African. And then, yes, it might be possible, but not something we're going to have it within 1 year or 6 months. But if we can work, yes, we can have at least a uniform dental of the Doctor of Dental Medicine graduates, Bachelor of Dental Science, and also the dental assistants. As I have come across during my African Dental Student Association presidency, we have different curriculum and different undergraduates program, which are not even matching and even in our continent. So yes, we need to come across closer, bridge the gap between the students and the professionals, and work towards having a uniform curriculum. Yes.
All right, Dr. Dit, and I appreciate your answers. It's been a very interesting session, and please, you can allow me to go forward uh, to Dr. Bwenji Robert. We appreciate you, and let's go to Dr. Bwenji Robert. We will be back to you with the questions that shall arise from the audience. Thank you. Dr. Bwenji Robert, uh, good evening.
Good evening, Jimmy. How are you? Thank you for having me. Good evening to everyone on the forum.
Yeah, you're welcome, Doctor.
Thank
Uh,
you.
Doctor, as the founder of African Dental Congress, as well as the founder of the In-Depth Community Dentistry Africa, how can national policies better support clinical facilities and surgical dental care to ensure they are accessible to the average citizen, not just those in urban centers?
Thank you. Well, to make sure I understand the question, do you mean how can we or how can a policy be designed in a way that it accounts for the socioeconomically disadvantaged people who cannot afford care? That's what the question means?
Yeah, you're right, doctor.
Okay, I mean the socioeconomically disadvantaged populations or communities that cannot access curative care. That's what you mean. How can
Yeah,
a policy help these people?
yeah, sure.
All
How
right,
can this force with them?
through the policy. Okay, so before I answer your question, I am going to just briefly and concisely describe what a policy is, and then I'll also explain how the components of the policy can be structured in a way that people who cannot access care can actually access it. So in short, how can a policy guarantee universal healthcare coverage or access to care, right? So first off, a policy is a blueprint that decides that oral health or the oral health policy is a blueprint that defines the importance of oral health in the health sector and its importance to the population, and also the roles of all sectors, all stakeholders in the promotion of oral health and making sure that services are delivered. And also the economic determinants of health are well addressed because the health sector alone cannot address all these things. Right, so we need to look at finance. We look at psychology. We have to look at a lot of other sectors: agriculture, manufacturing. All these other sectors have got a role to play in oral health. So that's what a policy does. A policy is like a constitution of oral health, and this constitution, in quotes, has got must have preventive strategies. And all of these components that I'm going to describe, starting with this first one, the preventive strategies, to be able for a policy to be of use to people who can account for it has to be structured. All these components have to be structured in favor of these people who cannot afford care. Now, statistics in Africa say, as of I think 2022, that only 17% of Africans can actually access professional
Mhm.
professional care. 17%. Okay. So what about the other 83%? What is happening with them? And we also know it's common knowledge that sub-Saharan Africa is taking, in addition to South Asia, sub-Saharan Africa is taking a huge burden of oral health, of oral diseases globally. And as I speak, 44% of Africans are living with the untreated oral disease. That is dental decay, periodontal disease, oral cancer, etc. So it's a huge crisis. And then look at us here. Yeah, we are having a dentist patient ratio of 0.44 to 10,000, which is pretty bad because the global average is 3.5 to 10,000. And WHO says it's supposed to be 1.3 to 10,000. So all of these problems here, or the challenges that we face in oral health, are only working against the majority who actually end up with the 83% who cannot afford care. So a policy, whatever policy that is designed, should be designed to make sure that these people, 83% can access the care. A policy to start off with the preventive strategies, and this include taxes on goods. Could you please mute?
Santos, please. Santos Wamwine, please mute.
Hey, sorry.
Santos,
Yes, please.
could you please mute?
Oh, sorry.
All right, thank you very much, Santos. Preventive strategies, I was saying, this includes strategies by government, and this could be central or local government, whatever government is in charge. Laws, especially against products like sugar, alcohol, tobacco. We need to regulate people. But then, who are we regulating? Who are these laws really affecting? Do they really apply to anybody? When we set these laws regulating sugar, tobacco, alcohol, and all the other risk factors for oral diseases, are they really well implemented? So preventive strategies must be structured in a way that these people are protected. But are they really working? Now, I also say, according to WHO, less than 50% of African countries have national oral health policies. So it's a challenge. It's a challenge, but I'll describe this, and it's almost ideal. If I describe it, it will seem ideal, but I hope it answers the question. So preventive strategy should protect these people. And first of all, we start with prevention. Obviously, before we start treating or delivering care, we need to first make sure that people are protected so that we do not fill a pocket with a hole, because whatever I put in the pocket will just be going through. So we need to first set up perimeter fences and nets and all these other protective mechanisms, preventive mechanisms, to make sure that whatever efforts we put in place are not being wasted. And this has to be in legislation, the preventive strategies. It has to be recognized by law, so they are they're enforced legally, and people who breach them are penalized, which is actually not really a reality in Africa, because the same organizations or companies and institutions and individuals that actually manufacture, promote these risk factors, tobacco, alcohol, and sugar, and the foods, drinks, actually getting tax holidays. All right, they're getting tax holidays, and the law is just looking the other way while they're flooding the markets with its foodstuffs. So preventive strategies should actually be well enforced in policies to make sure that people are protected before they actually fall sick. Now, after we have done that, now we know that dentists only constitute less than 1% of the population of the health workforce population in Africa. Only less than 1%. So that means our reach is so limited. And besides, we want to be in urban centers. Well, I think the rate of urbanization for Africa is less than 50%, I think. Could be less than 60%. For Uganda, here it's around 30%. Most of the people are in villages, rural areas. So now we are in urban centers, and the majority are in rural areas, and we and the medics are working in parallel. So still all our efforts, much as we have put up all these laws and taxes to prevent people from getting sick, we are still beat by numbers and our reach and our distribution, which is in urban centers. So we need to integrate. That is the second component now. We need to integrate with the medics because they're the majority and they have a broader reach than we do. And let's face it, the fact is medics, most of them there's a good number of medics in rural areas compared to us, the dental professionals. So we need to integrate also to make sure that we guarantee universal oral health coverage. Then universal access. Now, this is a matter of economics and social aspects as well. How do we make sure that people have access to care? It has to be well structured in the policy. Like I said, the policy is in the constitution of oral health. So it has to be well defined in the policy how we are going to make sure that these people, everybody, accesses care. So now how do we make sure that care is accessible We have to look at the distribution of health facilities. We have to look at the mechanisms you're using to reach people, etc., etc. So all these have to be factored in the oral health policy. Okay, and then obviously workforce development, the next factor. Human resource is key, and much as AI is coming in and robots are also coming up fast, but human beings will always stay human beings. And besides, it's human beings who come up with AI and robots. So workforce development is key. Do we have dentists? Do we have the auxiliary dental personnel? Do we have the support staff? And all the labor or the human resource that is required. And this is not only just clinical, could also be in governance. Do we have actually dentists who have the qualifications to become ministers of health? Or do we have dentists who, things like that? But now in Africa, the majority of dentists are at the level of diploma in education, and they go by different names in different countries. In Rwanda, they are therapists. In Uganda, they are called dental officers. In Kenya, they are called community oral health officers. I don't know. I think even Nigeria, they're called therapists. So they go by different names, but they're the majority. And they are trying to do primary dental care originally before dental surgeons came in. Now, dental surgeons are very few. Our esteemed speaker from Nigeria said there is less than 4,000 dentists in Nigeria. Well, good for Nigeria. In Uganda, it's less than 500, serving a population of 15 million. And not all these 500 are active. So now the gap between primary dental care and tertiary dental care is not well covered. And that's supposed to be done by dental surgeons or the bachelor degree dental doctors. And now if you go up to tertiary dental care, the specialists, how many do we really have? And what mechanisms have been put in place to make sure that we have a good number of these? Now we're looking at education, especially education. And then in education, do we have teachers? Do we have schools? Do we have the money to sustain all this, the infrastructure and the human resource that is required to run this workforce development? And then the incentives. If we say, Dr. Wenje, a dental surgeon, now we would like you to go to Ireland and study public health for 3 years and come back. Well, what is in there for me? Once I'm done with public health, masters in public health, am I going to come back to something nice, something better than being a dental surgeon that I was? So things like that, incentives, because we can't just impose these developments on people. You also have to be motivated to actually participate. So workforce development has got a lot to play also in making sure that people can access care. This has to be put in the policy and well, clearly done and actually enforced and implemented. And health promotion and education. Now we know education is very important, and that's how we get to know things. We are dentists today because of education, from education to be exact. So for anybody to learn anything, for people to benefit from a policy, they also have to have a component of education in it and promotion. We can't just write the constitution of oral health and sit on it, right? We have to also make sure that in this policy, there is a voice, okay, a mouthpiece, and that is education and promotion. We have to promote oral health. We have to advocate for it and for the benefit of the people. Those are the beneficiaries. So that's also another way to make sure that people can access healthcare, oral healthcare, universally by means of the constitution of the policy or by the authority of the policy. And the other thing is, after all these components are satisfied, which obviously they're not in Africa, that's why we're still struggling, we have to monitor and evaluate all this, our preventive strategies, the integration mechanisms, the universal access approaches, the health promotional strategies, are they working? We can't just start, we can't just throw laws in place and put taxes against these goods, and then we don't really measure the impact. There has to be measurable parameters to see if actually this 1, 2, 3, 4, 5, 6, 5, 4, 5 components that I talked about are being actually impactful and effective. And if not, why? And for most of the times, why they don't really work in Africa is financing. And also, I think this is only personal opinion. I think we are still dependent or codependent, I would say. I don't know, because I think we are waiting for people, I don't know, for WHO, the World Dental Federation, to tell us what to do. And yet these things are right here in front of us. I mean, if you're doing all this education, you've tried all the integration, you've done you've done all this community dentistry of extended care to people, you've put preventive strategies in place, but yet things are only going sideways. Now we have really done a monitoring and evaluation, and we have really seen that things are going sideways. Why are they going sideways? Well, let's look at companies like Coca-Cola, Pepsi, the soft drink manufacturers. What are they really doing towards helping the cause of prevention of the oral health policy? Are they actually working with the policy, or are they working against the policy? So when we monitor and evaluate such things, we get to see reality. All right, and that's the reality. The reality is the same people, the organizations that are making sweets and other carcinogenic foodstuffs, alcohol, etc., are the same people who are funding dental research institutions. I'm not going to be very specific with what organizations do that, but from the evaluations and monitoring, you get to see such loopholes, and then you go back and make things better, but all for the good of everybody. Okay, so monitoring and evaluation has to be very, very also critical, hypercritical, actually, I would say, and not sugar-coated, because this is where we fail. All right, we try to do all the above. We try to do prevention, integration, universal access, workforce development, health promotion, education, and then when it comes to monitor and evaluation, we fail there, because we look back and we've done everything right, and yet things are still going sideways. So what are we not doing? What are we not doing wrong? What are we not doing right, really? And the next is policy, governance. Now, we have done the monitoring and evaluations, and we are seeing that the policy is not serving the people. All right. So policy and governance now comes in. We have to look at government. We have to work with government. We are clinicians, we are technical people, but there's people who control everything. Now, can we just go and confront Coca-Cola? No, we can't do that. We have to follow laws, and we have to work with government to confront Coca-Cola, right? Financing. The earlier speakers, we reiterated so much about financing, and we're emphasizing that finances are a serious problem. And I really also actually do agree that finances are a serious problem. Or if you put all these structures together, without financing, we have problems. And also because maybe Coca-Cola and all these other big multinational corporations that are actually fueling these diseases have more money than our governments. So there's going to be a problem. there's going to be a problem. Now, political commitment. Will our governments really want to confront Coca-Cola and it is other organizations, the multinationals, the Johnny Walkers that are making these strong liquors that our youth are taking? And in Uganda, actually, it's really bad. 15-year-olds and above are tanking close to 10 liters annually on average of pure alcohol. That's really serious. It's almost close to Russia in the hard days, Soviet Union days. So it's really it's tricky. So if you ask me how the policy can really help so much, after I've mentioned all these components, now the last one is research. Now, Africa, according to UNESCO, Africa contributes less than 1% of global health research. So what data are we using to inform our decisions here? If you're not really doing any research, what data are we using to inform our decisions here? Maybe that's why we are making the wrong decisions, because we are borrowing data from other countries outside Africa to start making decisions, or maybe you're borrowing policies from foreign policies or ideologies that don't really apply here. Honestly, European culture cannot be the same as African culture, and the way they are governed is not the same way we are governed, and how they relate with their governments isn't how we relate with our government. So we must have our own ways of doing things. So we must do research. All right, we must do research. By any means, research is the only way we can make informed decisions accurately. All right. So I've talked about all these components, but are they really working? Let's talk about that. Are they really working? I don't really know. But we talk of money, financing, which is really, really critical. And I'm also thinking political commitment, which is under policy, governance, and financing, because it's government, it's the incumbent government that decides where the money goes. And as we speak, I don't know if it's WHO that expects at least every country should have 15% of its national budget put on healthcare. But in Africa, the average is still around what, 5 or 6%?
Excuse Doctor for cutting short.
Yes.
Can you unmute your camera?
Come again?
Can you unmute your camera, please?
I'm in a dark place. I don't know if you'll be able to see me.
It's all right. It's all right. If it is better, you can. But
okay,
it's all right. Yeah.
So I'm going to go back again to these components of the policy real quick. Preventive strategies, which include laws and taxes, legislations against sugar, alcohol, tobacco, etc. Integration of oral and general health, which is actually a WHO initiative that started in 2017. Then it was cemented in 2021. FIRAT came up with the strategy, the global strategy and action plans for oral health in 2022 and then 2023. So, and then universal access, which is key. Actually, we celebrated Universal Health Coverage Day. I think that was 12th of December. Every 12th of December is Universal Health Coverage Day. So you see, globally, these things that are in the policy are being recognized, really, but in reality, or practically, are they really being applied? No, not as much as they should be. Workforce development, dental schools, we still have 84 dental schools training dental surgeons. And about half of these half of these dental schools are in only 26 countries. 26 countries almost all the dental schools in Africa. Okay, all these dental schools in Africa in only 26 countries, and yet we have 55 countries. So what are the other 29 countries doing? How are they surviving without dental schools? The Gambia just got a dental school just of recent. I think they just graduated their first cohort ever, the dental school, the Gambia, you know. So we're really doing bad when it comes to all these things. And health promotion, education, how much of this are we doing? Last time I checked, people who have access to community outreach, access healthcare through community outreaches are only less than 1%. So it's really bad. Monitor and evaluation, do we have these mechanisms? Are we tracking progress? Do we have any systems that measure disease and the progress? Do we have these things in place? If we have a database for all these things, no, we don't. Some countries do, but not really implemented. Actually, we do have the national, the health management information system that measures and tracks all the other conditions in medicine or general medicine, but dentistry is not really included that much. And yet we have like 1,000 diagnoses that must be captured in the system so that we can track the burden of disease accurately to the dot. But even the 4 diseases, the major diseases that we deal with, we still do not have really clear information or data about it. So, and we're not really tracking back. We're just waiting for it to drop from somewhere. All right. Policy, governance, political commitment, financing. Now, financing. And then research is the last one. Now, financing. I'm going to talk about financing real quick. Financing. How do we get money? Now, we know that our governments are struggling. But we know also that telecommunication companies are making huge profits. And the last time I checked, the aid we get from abroad is only about 200 billion globally in Africa. And yet we are losing about 587 billion. Okay. And we are not even collecting what we are losing in taxes collectively. Our governments are not collecting what we are dishing out of the continent in taxes. So how do we really consolidate all this money and make sure that it's put in oral health? That's a question for another day. 6% of the national budget in oral health, but it should be 15%. So where do we get the extra money to make sure that because everything is driven by money. To build dental schools, we need money. To enforce these laws, we need money, because you cannot attack someone who has more money than you. To integrate, we need money. People can't integrate without incentives, with no structures. You have to build infrastructure, you have to put systems in place. All the things cost money. So how do we get it? Taxes are not enough, clearly, because we are failing to make 15% of the national budget on oral health. Actually, oral health is getting like less than 1% for most countries of the health budget. So how do we make sure that we boost the financing? So we talked about financing a lot, and my idea is, besides the financing we get from the government, I think also development partners and these organizations that are responsible for this huge oral health disease burden should also contribute. Coca-Cola, MTN, maybe MTN does not, but they're making a lot of money off people. Social corporate responsibility, that's what I'm talking about. We must really have to push these people to do social corporate responsibility. Now, why I say this is, if you look at Africa and look at India, Colgate, the projects Colgate is funding in India and the projects Colgate is in funding Africa, totally different. But we're all using Colgate. Why? Because Indians are pushing Colgate to help, to support. Africans are probably not. Okay. There's a lot of projects Colgate is funding in Africa, in India. Colgate is taking people to school in India, dental school. So we have to work with such organizations to boost the revenues we need to fund our sector. So we need to help government. In short, that's what I'm saying. We need to help government. You can't just sit back and just hope the government. These people are not dentists. First of all, oral health is not really well prioritized. So we need to work with these people. We need to have to make the policy work by any means, by advocacy and coming up with ideas to supplement what the government has. We need to sit on the round table with governments and actually draft oral health policies that work, that give us the powers to act. Now, associations, we talked about, Dr. Reddy talked about the African Dental Congress. But how many dental associations in Africa have got diplomatic recognition with, for instance, African Union? Is there any association in Africa that can actually represent all dental students and professionals on a global table that is diplomatically recognized? No, we do not have one. So we need one. And with this one, we shall be able to consolidate the resources we have, which is human resource and finances. Thank you very much.
All right, thank you very much, Dr. Bwenji Robert, for a very interactive session, and you've made and gave us big insight and overview on the oral health policy, where you started by giving us the introduction or by defining us what is really policy is and what is oral health policy is, and what should be the first 5 pillars of the oral health policy that should be composed of. And you've highlighted all the challenges that are facing not only across Africa, and suggested many ways to outcome them. And this was very interesting sessions. Here in the chat box, we are having some questions raised. The first one, but for the sake of time, will be short with the answers. Chrison, if I'm reading well, asked, how can dental organizations that already existing get aid, inform, any support? Dr. Bwenji, am I audible?
Come again? I lost you somewhere. You said the question was?
The question asks, how can dental organizations that already existing get aid, inform, any support?
Now the question, it's a good question. How do we get aid or any support? First of all, we need to know what the support is for. And also it's very important to know who can provide that kind of support. Okay, so how do we get this support? So what's the problem you're solving, first of all? Is it workforce? Is it infrastructure? Is it supplies? So if it's supplies, who provides the supplies? Who manufactures the supplies? So we have to start from the beginning. In the end, whatever the problem is, support can either be technical or financial. So if it's technical, you seek it from the experts that are relevant to your field and to the problem you're solving. If it's financial, there is financial institutions, there is donors, there is foundations that fund projects. So, and also the project or the solution that you're providing has to be really needed and has to be efficient. So how to get aid is one question. But can we handle that aid? Do you have the capacity to handle that aid? Is another question. So one thing I see that we struggle, dental health organizations in Africa are struggling with is the capacity to handle the support or the aid. In order to ask for it, first of all, leaders of these organizations lack adequate training in leadership. Because for you to get any kind of support, you need to know how to advocate, you need to know how to lobby, you need to know how to talk. Okay, you need to know who to talk to. But how many of us in the dental fraternity in Africa are getting any leadership training or any training in entrepreneurship or in a training in project development management, research, project proposal writing? You know, how many of us are doing that? And also, where are we really usually trying to get help from? A majority of us are getting help from foreign individuals and organizations. And that's also another thing that I find is crippling dental organizations. We forget that the people that we are trying to actually help are the very people who are supposed to be helping us help them. Before we go out there, ask for donations, grants, can we first try to solicit something from the people that we are going to help? They must have something. Sure, they have something. It's not much, but it's good to start with. Actually, it's enough to actually set up. If you want to help a village of about 10,000 people, you are a dental health organization, community-based, say, what do you do? Do you go, if it's the villages in Kenya or Uganda, do you go and ask for help from South Africa, from grant providers or donors in South Africa? First, no. You first go to this village and talk to the leaders and tell these leaders to collect $1, $2, $5, 2 cents exhaustively and see how much we raise. And then we see what we can do with this little we have raised. Okay? And then we build capacity to be able to deal with bigger aid and support, to be able to actually not just depend on others to provide aid, but actually have strategic partnerships which are of mutual benefit, not a codependency where we are begging. Actually, most of these grants, when we apply for these grants, there is a cutoff point. There's a maximum. They say we are providing a grant for the best project on this, and this is how much money we are putting on it, $20,000, and that's it. So everything you do must be within $20,000. And actually, if you went to the village that you're trying to help, you could actually collect $40,000. Like, really, that's what Ubuntu is. That's what Ubuntu is. We have to move away from the capitalistic mindset, because the people that we try to get aid from, the foreigners, have got their own imperialistic aid. Some of them, I'm not saying all of them, all right? I've worked with some of them, Dr. Marielle Parisu of Utah, the founder of Teeth First. She's a nice lady. She hasn't tried to impose anything on me. But most of these people that help us with money for these projects, you know, they have their agendas, you know. They get some kind of entitlement. And this, of course, and also if you add this limit to the money they're giving, you're limited financially, and also you're limited intellectually. Okay, because more or less, the person who is giving you money to financing your project 100% is going to dictate a lot, especially if they're not coming from that village. They will want to gain in some way. So let's not go out. Let's look within first. Trust me, if you go to that village, you'll collect $40,000. That is twice the money you get from a grant or from a donation. That's the advice I would give.
All right, thank you very much, Dr. Bwenje Robert, for the great insight upon how these existing organizations are getting aid, which was raised by Crison. Before I head on to the rural access and the preventive primary care, which will be assigned to David Odoi Watanda. There are some suggestions. The one in the chat box, the one was written by Dr. Niranjan, saying we need national health survey. And the other one was also written by Chrison, is a tax-free holiday on dental products, so that I think I should say they should give that can be easily be affordable by medical investors. African countries should also implement such policies to improve on dental sector. That are the suggestions that I've seen, and Dr. Edith has said apologies, requested her apologies to all, that she's leaving for the urgent meeting. And I'm heading to David Odoi Watanda. Good evening, David.
Uh, Thank you so much, moderator.
Hope you're
Fellow
doing well.
panelists. Yes, I'm fine. Fellow
Uh,
panelists.
uh, Hello. Uh, can you tell some those who are here who you are before we move to the question?
Yeah, I was just diving into that.
Hello. Hello, David. Can you hear from me? Hello.
Hello, I get you.
Yeah, sure. I can get from you.
Okay. So, my name, Public Health Dental Officer, and by God's grace, I'm the Executive Director of Dental Health Uganda, a charity organization, and as well as work in St. Francis, Nyenga, Specialist Doctors International, and Doctors Clinic Ginger. With that, I also do some part-time tutorship in Toro School of Health Sciences. Thank you.
All
I'm
right.
waiting
Thank you.
for your question.
Yeah. All right. Thank you very much, David. And concerning your enthusiasm upon the oral health activities that you do, what low cost or high impact models can we present to policymakers as quick wins for rural oral health? What are they?
Yeah, thank you so much once again, the moderator. Before we dive to the solutions, I would first like to take us through the problems. Because it is good to know the problems as you get well versed with the solutions. Basically, when talking about oral health in Africa, especially in Uganda, where I'm so much interested in, we must shift the conversation from hospitals to communities because the reality is simple. Uh, Most of the people who need oral health care will never reach the dental clinic, not because they don't have the disease, but because the system is too far. It is either too far, it is either too expensive, or simply not designed for them. Um, I want you to bear with me witness, fellow listeners, in rural settings, oral health care is not just a clinical issue. It is an availability issue, an access issue, affordability issue, and a system design issue. In fact, what we see or interact with in the facilities are the end results of what patients go through. Uh, they present with advanced infections, severe pain, and maybe late stage complication presentations. These are the end results. But what we don't see is the long journey patients go through to reach to us. So, based in having that as a problem, I came up with the low cost models towards oral health, and I believe they should be of high impact. I will basically base on prevention and community-based care. Uh, Ladies and gentlemen, I tried, as Dental Health Uganda, there is something which can't be underrated. We are talking of mobile and outreach dentistry. This one simply involves taking services to the people instead of waiting for the people to come to the hospitals. This has a sole goal of moving dental care from the dental chair to the to the community. This might not involve a lot of money, but it simply includes periodic holding periodic dental camps. Yeah, in these camps, we can hold them in the community markets, in the churches, and also you can decide to surprise the hospitals, like in Ugandan system, health center 3, health center 4, surprise them with some high top-notch dental care. And another way is rural oral health care outreaches. This one basically you can do in schools. Yeah, in schools you can equip them with the knowledge of oral health. And yeah, these ones will be the future ambassadors. Uh, I can clearly speak without any fear of contradiction that at Dental Health Uganda we have seen that outreach dentistry dramatically reduces or has dramatically reduced the oral disease, hence reducing the burden in the hospitals. That one alone shows us that Africa is more of preventive and more of outreach dentistry. Another game changer in this, other than the outreach dentistry, is what is known as the basic package of oral care. To some of us, this might be new. BPOC, I call it BPOC in simple terms. It is just a simple, cost-effective set of essential healthcare services designed for low resource settings and community level healthcare systems. Uh, it also got my attention by the fact that it was promoted by the World Health Organization to improve access to oral care where dentists and equipments are limited. This one alone shows that this system has already been or is already in existence. To dive more into this system, I would like to inform us that this system basically has three parameters of operation. You can call it the modus operandi. First and foremost, we have the oral agent treatment. Yes, the oral agent treatment basically focuses on pain relief and infection control. The, the main, we also know that this is the main reason as to why patients come to the hospital or need dental care. It is because of pain. They are pain driven. If patients don't feel the pain, they will never come to the hospital. So, this oral agent treatment, the patient has presented with pain, you do your assessment and diagnosis as a clinician or a public health dental officer, as a professional. Where need be, you can do exodontia, what is commonly known as teeth extractions. If there is pus, you do drainage of abscess, and you also have to manage pain. Basically, we use the traditional painkiller, paracetamol. There is also antibiotics cover. We shall need the antibiotics cover for the infection and prophylaxis. We shall mainly use amoxicillin and metro. That one works because, yeah, you can try verifying the cost of these drugs vis-a-vis the others, painkillers and the antibiotics. Another package under the BPOC, we have affordable fluoride toothpaste. Yes, this is just essential for preventing tooth decay at population level. Uh, we do or we should promote the use of fluoridated toothpaste. We should also have that distinct knowledge to clearly apply this fluoridated toothpaste. I don't expect as a medic, someone has fluorosis and you advise that person to use fluoridated toothpaste. That should be non-fluoridated toothpaste. But the main goal here is in this promotion of the use of fluoridated toothpaste, we can blend in or we blend in the teeth brushing techniques as we encourage people to brush at least twice daily. We make and we teach them how to brush, when to brush, and what to use for brushing. Uh, in all this, we try to advocate to make the fluoridated toothpaste accessible and affordable. Remember, access without affordability, that is not access. The third package in this is what is known. It is called a traumatic restorative treatment. This is a minimal invasive way uh, to treat cavities without expensive equipment. In fact, we use the hand instruments only without electricity. Now, if I talk of hand instruments, someone might think, okay, handpiece, since it has the word hand. Someone might think handpiece, not really that. We actually use excavators. You get equipped with your excavators, get equipped with your condensers, covers, mixing pads, and have cement. This one is restricted to glass ionomer cement because glass ionomer has that added advantage that after preparing your cavity very well, of course, using the hand instruments I earlier on mentioned, this glass ionomer, when applied into the cavity, has the effects or it releases fluoride. We all know that fluoride is anti-cariogenic. That is already a banger or something which would really help in curtailing or saving the teeth. So as I talked of this BPOC package, in a summary, oral agent treatment mainly focuses on pain relief and infection. Affordable fluoride toothpaste, which it is essential for preventing teeth decay through the encouragement of the use of fluoride toothpaste. And automatic restorative therapy, this one is specifically for teeth conservation. Instead of removing, you are conserving the teeth. Ladies and gentlemen, now let me sum up this about my presentation, and we need to really make a strong call with regards to these policies, given the fact that the World Health Organization promoted BPOC and other kind of and the outreach dentistry. It alone shows that yes, it is a system which is there, and we just need to make them work. The rural populations do not need complex solutions. They need available, accessible, affordable, and preventive care. There has to be a real paradigm shift from facility-based to community-based care. We have to shift from treatment to prevention. This is because Africa generally cannot afford to treat its way out of oral disease. Africa must prevent its way out. Uh, we should just operationalize what is already existing because they have a proven track record of work. They work. We can't afford to reinvent solutions. Ladies and gentlemen, as I finally submit, these policies we always say are tricky. Policies without implementations are nothing but just intentions. I beg to submit. Thank you.
Thank you very much, David Odoi, for a wonderful presentation. Uh, the package which is going to work to support or to give the guidance to the people going to do that community outreaches or community uh, wise activities in the dentistry. We appreciate the presentation. In the questions that were raised, we have one from Dr. Niranjan, which says how dentistry can be implemented. By that, I would like to add on how dentistry can be implemented and as well as teledentistry, and how can this benefit or support these outreaches that we usually have to do, or the health system or health system thing. David, can you hear from me? Hello, David.
Mm. Yeah, I beg you pardon. Come again. Eh?
Uh, all right, thank you. The question was asked by Dr. Nilanjan.
Yes, I can now hear you. Eh?
All right, thank you. Hope he asked how dentistry can be implemented, and I also added also how can it also
Yes,
improve those outreaches that are being made, or how can
I'm
it improve
getting you.
the oral health system? Thank you.
Or be implemented. Yeah, well, we all know, based on my Ugandan experience, this outreach dentistry or the government has some allocations for outreach dentistry, but it is not to its maximum. So I think we can have to bring, or we should have to bring some partners on board. Normally, it is common that this outreach dentistry is done by good Samaritans. People have decided to leave the rural areas, more especially dentists. They have decided to leave the rural areas for good Samaritans, as most of them, a number of them, as Dr. Buanje had said, are urban centered. So it takes a collective effort. Well wishers, you try to reach out to people, you try to go to these facilities and have workable plans in ways of executing. I believe the government provides support. The government can provide some logistical support towards these outreaches, depending on the country you come from. Yeah, but it is basically having partners, having organizations, charity organizations. They have always seen them. Yeah, thank you. Yes.
Thank you very much, David. It's really interactive session. And uh, allow me to go back to Dr. Franklin Aburime. Doctor, can you hear from me? Hello. Hello, doctor. Hello. Allow me to shift to Dr. Bwenje. Once Dr. Franklin will be ready, we will be back to him. Uh, Dr. Bwenje, according to the discussion that we've had concerning the health oral health policy, what can you tell us, or what would be the point to which we are going to work on, as well as to facilitate this oral health policy that we are going to engage or integrate the people from the rural areas or remote and south areas? Uh, can you give us a short, wise message upon what we can do for that? Thank you.
Oh, thank you. Yes. From the components I talked about, we can, because we like to, most of everything dental, high technology, dental schools, the big dental clinics, most dental clinics are in urban centers. And I understand why that is. It's economic reasons, right? So what if we shifted to the rural areas? But then how do we shift there? Okay, now let's put in the policy. We should say in the policy that dentists should be distributed, not according to where the money is, where the employment opportunities are, but according to where the greatest need is. We know the greatest need is in the villages, in the rural areas. So we should have more facilities in the rural areas than we do in urban centers, right? Now, okay, fine. Urban centers have more people, but is that true? Do urban centers really have more people than rural areas collectively? I don't think so. So we still need more facilities and more dentists in rural areas. And then also dental education. Most dental schools are in urban centers. So like, why does someone have to sit on the bus for 12 hours to go to a dental school in an urban center, which already has like 10,000 clinics? And then the 70% of people living in informal settlements are not really getting the care. So why they make so many clinics in urban centers, and yet most of the people in urban centers are not still receiving the care, and then the people in rural areas are totally neglected. So let's put dental schools in rural areas as well, and then plant clinics around them, because I'm sure if you put a dental school and a hospital in a rural area, private dental clinics will follow by default, just how it is, at least for Africa, the Africa that I know. So people follow infrastructure. People go to urban centers because there's infrastructure in urban centers. So let's shift infrastructure to rural areas too. Let's put very good internet in rural areas, good water supply, nice housing with nice facilities and amenities. People will feel, in fact, people would want to live in rural areas because they are quieter, they are cleaner, they are cheaper, So we need to just also look at change of mindset, change infrastructure, relocate infrastructure, redistribute infrastructure to rural areas, put into schools there as well, build more facilities there as well. The government is trying to do that, but not very much. At least for Uganda, it's not. Some actually rural areas have no dental facilities at all, like at all. And we have traditional dentists doing all the work and causing a lot of damage. And these people are not protected. And we can't even know where these populations are. That's how totally detached we are as dentists from our people. So we need to go to the villages, and then also we should also try to create it in the policy, because, like I said, the policy is the constitution. Like, we should make it law, because if we just tell people that do this, do that, they will not do that. So we should make it law and also create an environment, a conducive environment for the dentists and dental students to obey the law, right? That's what the policy is. Like what Anda said, if it's just on paper, it's just on paper. It's voiceless, it's powerless, right? It's only impactful if it's implemented. So you can't just put laws on paper and have no means to implement them. And you can't implement them, of course, by force. That has to be, people have to have a motivation, want to obey these laws. People should have a motivation. If they can get us fast internet and warm water, warm showers, and Netflix in a rural area as much as they would in Lagos, in Accra, and Kishansa, why would they not go to the rural area? I mean, if they're going to spend half as much they would spend in a rural and urban center and still make as much, why would they want to go to the urban center? So we just need to make sure that we have infrastructure in urban centers. And Europeans are trying to do that. A European rural area is almost like an African city, It has all of the infrastructure, gas, electricity, all that. So we should just make it enjoyable to live, work, get married, do business in rural areas as dentists. I think it's not an issue of just oral health policy. I think it's an issue of Africanicity. I think as Africans, we are running away from rural areas. Not just oral dentists, not just dentists, even lawyers. All professionals are. So we should not just work alone in this possible. We are very few, to be honest. Like, we have a very low voice. So we shouldn't just be thinking in isolation. We should look at this problem as a problem that is being is challenging many professionals too. And then we should also work with these professionals to make sure that we go to these villages. Because if you move infrastructure, services, amenities, all the things in rural areas, we can't just take dentistry there with no medical services, with no legal services, with no infrastructure that you find in an urban center. No. So it has to be a collaborative effort for us to make sure that dental services are taken to the villages. If we invest, let's invest in villages. And that's how things are going to go. Because even clinics, it's not like a clinic, if you go to urban centers, dental clinics were there first. No. Other business were there first. First food business is coming, then housing, then other things come in, alcohol, etc. Then dentists come in later. So we shouldn't always want to think we can do this single-handedly. No, let's talk to lawyers, talk to doctors, nurses, and we move together. That's the only way we can be able to actually effectively do this. Otherwise, it's just going to be talk. Thank you very much.
Thank you very much, Dr. Bwenji, for the great insight and advice and a great suggestion for what we can do that this health policy can go and benefit the rural areas as well as bring the national health policy beneficial as possible. Please allow me to welcome David Watanda to give us a headline and a suggestion upon the policymakers how this basic package of oral care and also mobile dentistry, how can we head on with that in policy, or how can we integrate it? Thank you. Hello, hello, David.
Yes,
All
yes,
right.
I'm getting you.
Uh,
Hello. Yeah, am I heard?
yeah, sure, you're audible.
Okay, then I please beg you repeat your question.
I would like that we have like a headline or your suggestion upon the policy, basing on the epoch that you've shared with us and also the teledentistry that we've talked about. What could be the headline concerning the policy and integrating these activities in the community?
Yeah, thank you so much, the moderator, once again. Uh, what can or what simply has to be done is basically we already have existing health campaigns. Yeah, fighting malaria. The I mean, we should just incorporate these into the already existing health campaigns. And also, what one of the panelists said earlier on, uh, we shouldn't only leave some work for the dentists. We should, we have the healthy system, we have the health workers. I talk of the nurses, I talk of the clinic officers, I talk of other health workers, VHTs, namely. These people, I think, should be equipped with well dental exam oral examination tools. They should be able to educate people, give oral health education. They should be able to examine and, in fact, given also clear pathways of referral. Most of these diseases, once handled at their early stages, they don't actually become a burden. So we have to train. This is what is called integrating oral health into the primary health care. Primary health care exists. We need just to put oral health care into primary health care such that we make it everyone's duty, everyone's call to try to fight in a way of preventing oral health. Because as if we keep on leaving oral health conditions or other things for only dentists to reach villages, dentists might never reach all the villages to implement these things. But if we try to bring in other people, I believe we can actually make it
Thank you very much, Watanda David Odoi. And uh, I would like to know if there is no one who is having a question. If you are having a question before we go to the closure of this, please raise a hand and we'll give you a floor. Anyone, please? All right, thank you. There is no one who is having a question, and if there is, they will be texting us maybe. I would like to appreciate the contributors of this Dental-Medicine Chronicle of today. It's a pleasure with you, Dr. Bwenje Robert, Watanda David Odoi, and we will pleased to be with uh, Dr. Franklin and as well as Dr. Redit Abebe. It's a pleasure with us to be with you all who participated in this and the Dental-Medicine Chronicles of today. And the topic was uh, oral health policy, integrating oral health policy in national health policy system. And it's now closed that we appreciate all who contributed. We appreciate FIRAT, the Foresight Institute of Research and Translation, which gave support and technical support for the development and also the implementation of this uh, program, and also the Dento-Medical Society Rwanda, which made the headline and make this a possibility. Looking forward to the change of the policy, looking forward to the implementation of the policy which will benefit the community. Thank you all. Best wishes ahead. Thank you.